I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine. And maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for PrecisCa, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti, I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
This is a 50-year-old African-American male, former smoker, with newly diagnosed stage 4 adenocarcinoma, the left lung, harboring an EGFR mutation with spinal cord compression and bone metastases. And question is, what systemic agents are recommended in this case? And is there a role for additional radiation? So patient presentation: presents with lower back pain after picking up a bag in the grocery store in mid-September. The x-rays were normal. He proceeds to physical therapy with no relief of symptoms, seeks care with a chiropractor. The pain worsens. He eventually gets an MRI of the spine that reveals diffuse osseous lesions, and the patient is referred to the emergency department. He has a performance status of 0. No past medical history. He's a former smoker, but quit 30 years ago. He had a 6-pack year history of smoking, so a light smoking history, social alcohol use, family history consistent with a father with prostate cancer. We don't have the imaging here, but the CT scan reveals multiple pulmonary nodules, with the largest of the left lower lobe measuring 3.3 centimeters. He's got some hilar and mediastinal adenopathy. He has a T8 compression fracture, which may be explaining some of his pain. He has large lytic lesions at C1, L1, L5, and a pulmonary embolus in the right upper lobe and right middle lobe. The MRI of a CTL spine just shows diffuse osseous disease. He has a C1 lytic destructive lesion involving the left lateral condyle, and then has severe cord compression at T1, L1, and L5. He gets a biopsy of the left lower lobe nodule. That's adenocarcinoma. That's EGFR positive. The MRI was negative for interparenchymal lesions, but shows a 2.8 centimeter calvarial lesion. Unfortunately, this is quite a common scenario for us for these patients presenting with widely metastatic disease, specifically in the bone, which remains a problem with vertebral metastases and cord compression. Patient gets 8 fractions 24 gray of plan 30 gray and 10 fractions of radiation to T8. During treatment, his back pain worsens. He gets a spinal fusion of T8 performed by neurosurgery. And after completing rehabilitation, he meets with medical oncology, who recommends Osimertinib. So before we get to the systemic agents that are recommended in this case, maybe we can talk about the role for radiation. Is there, the patient didn't get all planned doses of radiation to, I believe, T8. Is there a role for radiating other sites as well? Dr. Kern, I'll put the ball in your court first to discuss the radiation options for this patient.
Yeah, thank you. Yeah, it sounds like a very bone-seeking, aggressive lung malignancy. We heard a summary that at 2 other locations there was severe spinal cord compression and large lytic lesions in the cervical spine. So it would appear to me that the identified cervical and lumbar area need to be irradiated. There's not going to be a whole lot of other opportunities to intervene before he becomes compromised. Anytime you have to interrupt radiation to do a decompressive infusion, you do wonder whether that should have perhaps been the initial approach. Perhaps do the spinal cord decompression at T8 initially, and then radiate that as well as the other lesions. In terms of additional radiation, probably not a bad idea. Many times the spinal surgeons really want us to wait quite a while if they are doing grafting. So whether it benefits or not, it's hard to know, but I'm assuming there was a lot of aggressive disease, and long-term it'd be better if you could do some additional radiation there, but probably more importantly, treat the untreated areas.
Okay. Dr. Govindin, what do we generally recommend for these patients? I'm assuming this is an EGFR common sensitizing mutation. Doesn't say that, but let's assume it's a 19 or 21. What would you recommend? And would you also recommend a bone strengthening agent as well?
Yeah, I think it's fairly straightforward in the presence of sensitizing mutations like exon 19 deletion or L858R. Osimertinib is the appropriate agent. I would consider denosumab or zoledronic acid given the extensive bony metastasis present here. It offers only a modest benefit, but I think if ever there's a situation to use it, perhaps here it is one. And one thing I want to quickly point out is that addition of other agents like chemotherapy, bevacizumab to osimertinib in the frontline setting is in an investigational approach. Also, I would urge practitioners to keep this in mind that there is absolutely no role for combination therapies with a checkpoint blockade with EGFR inhibitors. They are disastrous, they cause lung toxicities, so it should be avoided.
Great points, and clinically relevant ones, given we see these patients frequently, and oftentimes we want to treat these patients with immunotherapy, but for these driver mutation patients, we certainly want to pump the brakes on that. So final recommendations here are to consider treating the untreated sites of disease in the spine. Correct me if I'm wrong there, Dr. Curran. And also consider some additional radiation post-surgery for that T8. And then osimertinib would be the standard here without any combination chemotherapy or bevacizumab, and certainly not a checkpoint inhibitor. Let's just throw in a different scenario here. What instead, if this patient did not have a sensitizing mutation, but had an uncommon mutation? Dr. Govindin, how do you manage these patients routinely that have uncommon mutations? We have certainly some data in different TKIs. Probably the wealth of data comes, you've said before, with afatinib. How do you generally manage them?
So I think there are three mutations to watch for. One is the common mutations that everybody is familiar with. 90% of EGFR mutations are exon 19 deletion or L858R, and they respond well to osimertinib, erlotinib, etc. The second is these kinds of complex mutations, like what you just mentioned, 719X. There is some data that afatinib might be effective in this population, and again, they don't respond as well or for as long a duration of therapy time as osimertinib in classical EGFR mutation. But afatinib has probably the best data at the moment, and osimertinib has some activity in this population as well. If you use afatinib, it's important to keep in mind that the full dose, 40 milligram, 30 milligram is better tolerated than the higher doses. But diarrhea is a major problem with afatinib. The third group, which is really tough, is exon 20 insertion, EGFR. And there are a number of agents being tested in the clinical setting, but again, none approved yet. It is not a group that responds well to osimertinib. So this is really a tough challenge, and hopefully we'll make some progress in the coming years.
And if this patient was started on afatinib and developed disease progression, would you interrogate T790M? Would you move to chemotherapy? How do you manage these patients with these uncommon mutations on afatinib?
It's not very common to see in these uncommon mutations EGFR T790M. So it's not an unreasonable thing to check for other alterations, but I doubt very much whether that would yield useful clues. We would treat these patients with conventional platinum-based chemotherapy drugs combination. And if you're going to use, for example, a pembrolizumab, I typically wait for about 3 months or so after completion of EGFR TKI. Again, I don't have any data to suggest that. Anecdotally, I've seen patients who have come off from checkpoint blockade go on to EGFR inhibitor getting pneumonitis, and the other way around too. Patients who have been on EGFR TKI and then go on pembrolizumab or other agents get pneumonitis seem like little bit more often than I would see otherwise. So I usually wait for 2 to 3 months before we start checkpoint blockade in these patients. I would give them just platinum-based doublet therapy.
Do you ever consider adding bevacizumab to that platinum-based doublet therapy, or usually just platinum-based doublet therapy post-TKI?
I think it's a good question. People have made the point that the subgroup of patients with EGFR mutants may respond well to VEGF inhibitors. But frankly, I'm not persuaded by that argument, so I don't. But if people are comfortable using VEGF inhibitors, there are data to suggest that the addition of bevacizumab to chemotherapy improves outcomes. This is a famous Alan Sandler study, and so it's not unreasonable to use it, but I don't.
Okay. So for this patient with an uncommon consideration of afatinib, if afatinib develops disease progression on afatinib, consider chemotherapy alone without bevacizumab. And if you are going to use a checkpoint inhibitor, waiting some time elapse, at least 3 months post-TKI.